Minutes of the last meeting. Motion carries. We have the treasurer's report.
No, just my scarf.
Is there any discussion on the treasurer's report?
I'll make a motion to approve the treasurer's report as presented.
Motion is made and seconded to accept treasurer's report as presented. All in favor say aye.
Aye.
Opposed, same sign. None present. Measure passes. My gosh, we're moving along quickly here.
Hey, the medical staff met last week before the storm, so able to have that. They approved the credentials on two providers. The first of which is Dr. Paul D. Wardlaw, W-A-R-D-L-A-W.
Thank you.
Family practice, courtesy privileges for that.
Okay.
So pass that around if you would, sir. The other privileges approved by the medical staff last week at their regular meeting were for Jessica Renee McMahon, APRN, Allied Health Services, and credentials on the Allied Health staff. Renee is spelled R-E-N-E-E. McMahon is M-A-C, capital M-A-H-O-N.
Mr. Chairman, I'd make a motion that we approve Paul D. Wardlaw, M.D., family practice with courtesy privileges. Excuse me. And Jessica Renee McMahon, APRN, to Allied, part of our medical practice at the hospital.
Motion is made
I'll second it.
to accept the McMahon and Wardlaw. The staff is seconded. Motion, all in favor say aye.
Aye.
Opposed? Carries.
Thank you. Appreciate that. Sorry. All right. Start off with, we got a nice card around Christmas. First of the, well, it was actually after Christmas, while I had it at the January meeting, but it's from Elizabeth Sheldon. I'd like to pass that around. Again, compliments on basically on nursing staff and other staff here at the hospital, and I've already shared that with staff, but wanted to make sure I shared it with all of you. So there is that. Several things going on, and I'll go through my report in no particular order. As we discussed at the January meeting, we're looking at integrating our electronic health record with a state database that tracks prescriptions, especially prescriptions for controlled substances. Just staying in that vein, we have not heard back from our EHR provider on where we are with those interfaces and what's required. But just today, we got a couple of pieces of information that apply to opioid prescribing. There are some new protocols, new guidelines from CMS, the Center for Medicare and Medicaid Services, on opioid prescribing, and also got today that there's going to be a couple of webinars to go over that, sponsored by the University of Kansas Hospital. So we'll be getting our providers into that and looking at this was aimed at primary care providers, which I provided to our clinic, dental care providers, and pharmacy providers. So I dropped off copies at Dr. Guy's office and at Patterson Pharmacy for those folks, so that we're all on the same page as far as monitoring opioid prescribing. So wanted to let you know we've had several discussions on that we continue to do that. In your board packets this month, we included the confidentiality statements that we generally sign in March, just for your review, so you understood again what you're looking at signing. You got picked out a couple of those this evening already.
I had some questions regarding that.
Uh-huh.
First of all, I've never seen one before. If I've signed it before, then my mind is blank on that. First, I wanted to know, I've heard of HIPAA, however, I don't know about corporate compliance. I don't understand what is meant by other policies governing confidential information. I don't know those policies.
Okay.
It says, it talks about access. I further agree that if I am provided access credentials, what does that mean?
Well, if you were provided credentials, let's say, to review certain medical records or personnel files, then you would have to, you basically agree to keep everything you see and read confidential.
Okay, so they're not called access credentials. It means access to credentials?
Yes.
Oh, okay.
Yes. Access, well, you're given credentials. They give you access to certain times.
Oh, okay, okay, that makes sense. I couldn't understand what that said. Okay.
Yes.
Then my next question, it says there are state and federal laws that we must adhere to. Other than HIPAA, what are they and where are they?
I would actually have to research that and get that to the next meeting.
Okay.
So we can.
And then the statement mentions disciplinary action and immediate removal or termination. So I assume that means removal or termination from the board.
Yes, ma'am.
And who would enforce the disciplinary action or termination? Like, can you be voted off the island?
Yes.
I assume because the hospital board members are appointed by the commission that the removal would be up to the commission.
Well, we would take that to them, but it would be based on a motion and action taken by this board, which would basically be a recommendation to that commission.
And then the commissioners would make the decision. Okay. And then it states that by signing the statement, I am stating that I have read and understand the provisions for the confidentiality of information contained in the Notice of Privacy Practices and the Corporate Compliance Program and the Code of Conduct, and I agree to abide by their terms and provisions. So is that 3 different documents or manuals?
3 different.
Okay,
Yes.
and to my knowledge, I've never seen any of those. So do you have them here tonight, or am I supposed
Not
to
tonight,
access them
no.
online? Or
No, they would not be online. We would not
Okay.
those online, that's my knowledge. So yes, we provide those to you
Because really,
prior to the next meeting.
we really shouldn't sign it before we read them, because it says here, I have read and understand.
Laura, I'm glad you brought that up, because I was going to ask you a question too. I think we need to review our board bylaws, because I think we need an ethics committee. If there should be a violation come up, then maybe an ethics committee would review those. So that's just a suggestion. I know by going through our bylaws, they don't really, I think our bylaws are so old, they don't, it was written before this here was. There's a possibility, I guess.
So then you think there needs to be a committee to rewrite the bylaws to include this, or what?
I would suggest that, yes.
Well,
Or not include that, but include if there is an infraction, how's it taken care of?
Because I've been on here for years, and this is the first I've seen of this. This is the first I've heard of all these laws and books, and I don't know a thing about it.
Well, I basically, to the best of my knowledge, we celebrate the confidentiality statement. It's celebrated here generally.
Okay. So, yeah. So I guess I need to request copies of all these things I have to read before I can sign this.
And then one other question, do all our hospital employees, do they sign the same sheet, or is there, do they have something different?
It's very simple. Yes. And we go over that with them.
Do they sign every year?
And then who wrote this? Is this by this group that wrote it, or did it come off the internet, or how did we get it?
It's by our corporate compliance.
Is that like a committee, or is it?
Well, no, it's basically the corporate compliance manual, which is in the process of being updated as we speak. And so we basically have an agreement with Great Plains Health Alliance that provide that kind of support, that type of paperwork and manuals for us. And the other place we get support for corporate components is Dick Hay, Postal Seat. And if we were to look at updating the bylaws, if I could give a recommendation, I would recommend we go through those people, Mr. Seaton.
That's exactly what I was going to
Right.
suggest, is that since there are legal
Ramifications.
Because these
areas to be
laws-
covered, wording, and all of that kind of stuff would be appropriate.
And then for the rebuttal.
Okay. So, your corporate attorney is Dick Hay, and who is that company you said you guys use?
Postal Seaton he's a partner of Postal Seaton. It's the largest, I think, healthcare specialty practice in the state of Kansas. Just plain law firm in the state of Kansas.
Oh, no, I thought you
Offices-
said that there was another group you used.
Well, yes, we also use the Great Plains Health Alliance for administrative support and some of these things.
Okay.
Let's bring that up in new business.
All right, okay. A couple of other things I wanted to touch on basically. As I announced at our last meeting, we basically had been a conditions of participation survey for Medicare and Medicaid surveyors per year. We did very well in that survey. We only had one citation, and that was on our emergency preparedness plan. We did not have any clinical or medically related citations whatsoever. And so I'll be submitting the plan of correction for that on Thursday this week. Did not get the basically sheet that tells us what we did wrong and what we have to do to fix it until Thursday of last week, so I'll be following that on Thursday of this week. It's just a review at that point. Last, a little over 10 days ago, we had, it'll be 2 weeks on Thursday of this week, we had a federal fire marshal inspection. And so we had half a dozen citations on that. I've already filed the plan of correction. Some of the citations basically just for your information, one of the doors to the boiler room is not closing automatically and being sealed properly, so that was fixed the first day. The other thing that silence on that we've already acted on is that we're not allowed to use space heaters based on federal law anywhere in the building. So that's probably the most onerous thing that we have cited is on the space heaters.
Where did we have them? Where did we have them?
Primarily under the desk here, under the desks in the business office, which is kind of a cold, drafty place. They weren't in it. We knew they weren't allowed in any patient areas.
Right.
We've known that for a while, but we had the state fire marshal was in November, did not mention the space heaters, but the federal one did mention it, so brought that up. So we are in the process of getting that remedy. We continue to work with the Drs. Chima on getting them relocated here. They are going to be here next week to tour and look at some houses and things of that nature. I don't have the dates from them yet, but there are several properties they're looking at, not only for purchase, but at least one rent.
I have a question about that. So we don't have a start date for them to actually work here?
Not
do we?
yet. Primarily what we're waiting on right now is making sure they have a Kansas license. I did not check on it today, but we checked on it last Friday, and their Kansas license hadn't been approved yet. So the holdup is waiting on the State Board of Healing Arts to approve their license, and then finish that basic credentialing that goes with that. As soon as that is done, we will set a start date, and they're looking at housing. It's been basically 5 weeks or so, 4.5 weeks.
I was going to ask about that. How are we going to handle the move? Like, are they paying? Are we paying?
We're paying for the move. There's a relocation allowance.
Okay.
So yes. We have a relocation allowance built in the contract for that.
So do you have any ballpark figure when we can expect them?
I would expect them to basically one of the things too is to make sure the weather gets good so that they can get here. Hopefully visit with them a little bit more about that next week. They're ready to move here. It's just finding a place for them to land, and that's what they're going to do next week. So we'll visit them about those items. Just to touch base on some continuing things, Lincoln Park Manor, I don't know, at one time I was in the working group of that. I don't know where those particular discussions are going. As I kind of hinted at or mentioned in the last meetings, most of that is taking place in executive session of the county commission letter through attorney-client privilege. The last thing I was asked for from county attorney for the names and contact information for the nursing home management companies I had contact when our Lincoln Park Manor working was still active. So that's the only new news I have on that. So
I'm sorry, I don't understand. What did they want you to give them, the name, the contact number?
the name and contact information for nursing home management companies we've been in contact with as part of our work. We're working with the Sunflower Health Network, all of the hospitals, and we're now up to 26 hospitals in that organization. And one of the, we've identified a couple of joint concerns. We now share on a comparative basis our quality assurance, quality improvement statistics. Those are blinded to everybody. So we just see that in the background. The other project, two projects we're working on is number one, trying to develop our own patient satisfaction methodology that we can use rather than relying on the outside firms. I think that we can pay for that out of our due structures and things of that nature. We're also doing some things with workforce. We're pretty happy with the things we do with, say, nurses, traveling nurses, temporary nurses. We use all staff out of Great Bend. But we need backup for things like radiology, laboratory, and some of the more esoteric things. It's hard to find backup to give people vacations and things of that nature. So that's one of our ongoing programs there.
So what are they doing exactly? Like, are you sharing with other hospitals?
Yes, all 26 hospitals are coming together. We're working with an outside group called Connexus to look at developing our own, basically, for lack of a better term, what we call in the business a float pool of some kind. So that's part of what we're doing. So I think those are both good projects. Be able to pull patient satisfaction into our own area. One of the problems with letting CMS dictate all of that, when they dictate the satisfaction surveys, we rarely get enough people involved to get what would be considered a statistically significant pool from which to draw answers and make conclusions. So by bringing that into the hospitals themselves or our hospital group, we can get better information on patient satisfaction.
So when you talk about sharing quality assurance, that's with 26 other Kansas hospitals? Or who do you share those with?
Sunflower Health Network hospitals. It's all blinded.
Okay, so
they don't know.
Right, I know that.
Who's in it, but we don't see individual hospitals.
Right, but that's who's
but
in
we
it
can
is
compare.
Kansas hospitals.
It's like those surveys, statistical information I used to share with you,
Right.
where we were in the top 3 of the hospitals in Kansas.
Okay.
So it's that kind of sharing only in a smaller group, and we can just kind of compare blinded statistics and all of that, which will. We're still developing the reports, but that'll be available to share with you at some time in the not too distant future. But it looks not only at quality items like falls and things of that nature that we're used to, but we'll also be doing some comparisons on financials and things of that nature, financial status and so on and so forth. So there'll be good planning tools overall for Tanya and I, and just information things for the board to see how we should. Another thing I want to touch base on, we had the people from LifeSave, the helicopter and ground ambulance company that is the preferred provider for the Kansas Clinical Improvement Collaborative here late last year, early this year, I can't remember exactly when it was, but they landed a helicopter over here. And we were basically the base for a day. They based their helicopter here at Lincoln County. We continue to work on a partnership with them, and they're going to be here again tomorrow from 1:30 to 4:30. And I don't know, Jill, if the Sentinel will be interested in coming up and talking to them. We're going to be beta testing one of their apps, probably with a couple of other hospitals, but it's basically trying to improve the speed at which we can get either air or ground ambulance here to take care of our patients that need transfer.
And I think we've talked about, I can't remember, where do they come from?
Well, right now they're based out of Jabara Airport in Wichita, and they're the ones I've talked about earlier that need to put a new base somewhere in north central
Right,
Kansas.
that's what I
to
thought we were
serve
talking
this
about.
area.
Yeah.
So that's kind of why I'm dancing with them at the cotillion, so to speak. I've got some co-conspirators in on that, like my chief nursing officer and some of the other providers. And we had an incident, it'll be 2 weeks this Friday, that illustrates the need for better EMS support, not only here, but in all of Kansas. We had a patient present to the ER on that Friday afternoon in diabetic ketoacidosis. She had a blood sugar of 785. That's extremely high blood sugar. She was very, very ill. The ER provider on duty assessed her, started her on an insulin IV, an insulin drip IV to try and help control that blood sugar. Because if your blood sugar is basically over 110, you're in diabetes trouble with that. So hers was basically 7 times that, and then some. But our major problem was it took us 2.5 hours to find an advanced life support ambulance who could transfer her from here to Salina Regional for treatment. We called 9 different services, including LifeSave. Their closest ambulance that was available at that point in time was in Dodge City. We found another ALS ambulance in Wichita. And finally, after 3 calls to the Salina Fire and EMS, we were able to get an ALS rig from there and transport the patient to Salina. This is continues to be a problem throughout rural Kansas. And I think we're all aware of this, but it's just getting worse as to find paramedics to staff our ambulances. And so one of the things that we'll be doing is State Representative Don Heineman out of Dighton is holding a series of hearings this whole spring on healthcare problems in rural Kansas. He's going to be holding some hearings sometime in the next 2 weeks regarding EMS as well as some other things. So I've talked with Chad Austin at the Kansas Hospital Association about developing testimony to present in front of that committee. The provider on call that day was Sarah Biggs, and she would very much like to attend that as well. That's not confirmed. It's something we're working on, but I wanted to inform you that we're going to try and help address this. I don't know what we can do, but having a viable EMS system that can do immediate ALS transfers is important to everybody in rural Kansas. And we just that's one of the things we've
So-
just got to work on.
We have paramedic ambulances, but not to the extent that she needed.
Well, we have paramedics, but we don't have enough to staff them 24/7. And that particular day, there were no paramedics available in Lincoln. We also called Russell County, Mitchell County, Ottawa County, and Ellsworth, and were unable to find a paramedic to man one of those ambulances. And so, fortunately, we can manage that diabetic ketoacidosis for a short time here via that insulin drip, but she really did need care in a tertiary care facility.
Well, it sounds like when we do our little senior day, if we do that again this year, we need to talk about the need for paramedics.
Yeah.
How many years does that take to get?
Oh, that's a
Probably close to 2, yeah, it's an associate's degree.
yeah.
So that might be something kids would be interested in.
A lot of the problem is the states change the testing requirements for EMS just to become an EMT.
Mm-hmm.
Now probably, I would guess at least 60% of them can't pass the test.
I know people who quit because of the state changes.
And so it's kind of a stair step. You start out in EMT and then you move up. It's pretty difficult to just say you're going to become a paramedic.
Mm-hmm. Well, what I fault is a general push in all of medicine to over-credentialize everything. And that's been a problem in medicine for 25 or 30 years now, is to over-credential.
Well, it's not just medicine, it's not everything.
Yeah, but that's just my guess. And we're over-credentializing everything.
Yeah.
The other thing I'm working on is, we had a strategic doing committee and we got funding late last summer and the early fall to do that. I'll be trying to pull together those meetings in the next month or so that we don't have to give back the money. But we'll have that, and the purpose is to develop, again, that strategic roadmap, that strategic plan for maintaining the healthcare infrastructure here in Lincoln County. So I hope we'll be able to pull together that group. I'm looking at about 12 to 15 people. Kelly Larson and I are working on that. So we'll be getting that together. I think the rest of what I have, we need to probably discuss in new business. In your packets was a draft of the budget for your perusal. Generally, we approve the budget at the March meeting, but it's in your packet for discussion. So, Mr. Chairman, I would suggest that be something maybe under new business that we should discuss. And I believe that concludes my report, unless there are any questions at this point in time. I will have one other piece of new business. I have the community-based primary care clinic grant, 90% complete. One of the things I'll need from the board, again under new business, will be a request to approve the chairman signing the grant application cover sheet. So the budget and that grant application will be, I'd like to defer those until new business. Yes, sir.
Do we have any old business to drag forward?
Yeah, I have a couple things. One was, I just wondered, because I mentioned the parking lot last month, obviously, we can't fix it, but have you had a chance to look at it, and is there any kind of plan for
Well, I think the only thing we can do is wait until things dry out and bring in gravel. Steve Ladd and I have talked about that. I don't know that we have the financial wherewithal to pave everything again. But most of what's on the south side here has been gravel, and as you can see from the piles and piles of snow, we're pushing a lot of gravel into that, and the same with back here.
Okay.
But that's about all you can do with the skid steer. But yes, we
Do that in the spring, probably. Okay.
Well, it depends on, how much it rains, as much as anything else, and I'm just going off, you put down, try to put it down between rains when it's fairly dry and roll it in. But yes, Steve and I have discussed that.
Okay,
So,
good.
yes.
The other thing I wanted to ask about was the house in Sylvan Grove. I called the city clerk today, the one that's next to the clinic, because I wanted to just get it straight once and for all. And she said that house is not included in the grant proposal.
That's correct.
That the city clerk, the mayor, and the city council are all under the impression that Lincoln County Hospital is going to tear it down, like we said we were going to a number of years back.
Well, basically, I think what we're waiting on is the county. That actually, when Mr. Finch was attending our meetings, we had, when the county has the opportunity, they were going to take it down. Last year, I talked with Mrs. Hill and on a couple of different occasions, and we made sure that the sewers and the gas lines and everything of that nature that had gone to that old house were capped.
Right.
And we were ready to go. So we basically, I think, as an organization, kicked that up to the county. And we were kind of waiting on the county to take action on that. I can go back to that, but it probably won't get done till summer now.
That's what I was wondering, summer. So if we wanted to make
it's
sure
supposed to be on their agenda, but
it is, on the commissioner's agenda or
the
whose?
county commissioner's agenda.
Okay.
yes.
That would be fair to ask,
that's what
right?
I thought. It's fair to ask, I think.
Okay.
I think, and it may be, it's probably opportune to ask now again because Mr. Finch is no longer on the county commission, and our representative is Randy Logan.
Right.
And so he's been invited to this meeting, so but I may have to take the opportunity of one of us to visit with him separately on that. But yes, we had people ask to scavenge things off that house, and we approved that.
Oh, you have? Okay.
Yeah, window frames.
Yeah.
One of the window frames.
Decorating.
That nature.
Too bad they
Maybe
didn't
the
want
whole
the
thing fall
house.
down. But yeah, so we've been working on that basically since I got here. So.
Right. Oh,
And
before that.
And
Yeah.
well, I
You've been
only
working on it
testified-
since you got
I can
here.
only testify to what I've done since I've been here. But it's been in the grant, and out of the grant, in the grant, out of the grant. Right now, it's out of the grant.
Okay, and then I had another question about our pain contracts.
All right.
Pain contracts, I want to ask how those work. Because, okay, a pain contract is something a person signs, right, if they're receiving medicines, opiates, whatever they're receiving.
Well, yes, if they're undergoing treatment for pain, yes. Our process was, and we started this, I think a little over a year ago, was to get all those patients to sign contracts. And basically, the contract sets out standards of behavior that we follow and that they follow.
Right.
And
So then is drug testing or random drug testing part of that?
supposed to be, yes.
And how many drug tests have we done in the past so many
I
months?
don't know, I'd have to check.
Can you check it for me?
Yes.
And then the other thing I wondered was, is there any kind of policy about what happens to them if they fail the drug
If
test?
they fail the drug test, they're basically out of practice.
So is that like a policy and procedure, or how that is all
That's
written
part
up?
of the pain contract,
Oh, the pain contract is the policy that
Right.
says that if they fail it,
Yes.
they're out.
Yes.
Okay. Yeah, I would just like to see, because what way is there to see if they're living up to a pain contract if we don't do drug
Just the
testing?
random drug test.
Right, okay.
And we are, I think we discussed this last fall, and as I recall, we were getting people on those contracts. allegedly we're doing away with drug tests on testimony. I will look into that.
Okay. So then the hospital doesn't need a policy regarding what they do with those?
No, that's, it's in the contract. It's written into the contract. You do X or Y happens.
Okay. Okay. I just wanted to see where we were on that because I had asked about it a while back and then I dropped it.
Yes,
Okay.
Any other old business to bring forward? If not, we'll move on to new business. Approve the accounts payable or discuss it.
Check in here to
I'm sorry?
check in here to Chimas.
There were, yeah, there were a couple to each, yes.
And for what?
Those are basically a sign-on bonus for them. We'll also be paying the relocation. That's standard in these kinds of things.
I'm ready.
Mr. Chairman, I move that we approve the accounts payable now $734,000.
Second. Motion made and seconded to pay the bill. All in favor, say aye.
Aye.
Opposed, same sign. We pay the bill. Alan, you want to discuss your committee, or how do you want to handle it? Do you want
I think Mr. Rodney brought up that Great Plains Smith with some things with changes from them. They discuss that, something we should want to form or set up a committee to look at it. I just think we need to have something in the bylaws if we have a case that should be handled. I don't have that.
Let's table this for the next meeting, we'll make an issue of that. Kind of loaded this evening.
Mr. Chairman, I also think it'd be a good idea if Steve contacts Kansas Hospital Association. What time do the people that come out and help with the road responsibility? Not reduce their salary.
Okay. Before we move on to sessions, Stephen, you had a motion to, you want to
Are we in
talk
new
about
business? Okay. The community-based primary care grant, which we've applied for on an annual basis since I've been here the last 3 to 4 years, and it was due March 15th. And the application basically needs to be signed by the chairman of the board, trustees, and I have to sign it as well, but I thought it was something that the board for somewhat formal sense, so I would ask that one of the board members make a motion to go ahead and have the chairman sign the grant application, community-based primary care clinic grant, state fiscal year 2020 for
give us a summary on what they your special for?
Basically, what we do is we apply, we're maxed out at $50,000. We're applying for $50,000 and then maxed out at $50,000 cost. Basically, to subsidize the salaries in this coming state fiscal years of Dr. Arshad Shiva and Dr. Yasmin Shiva. So it goes to subsidize their salaries primarily. Up until this year, we have been using those monies to subsidize Hattie Dale's salaries as well as Dr. Rigoni's salary. I thought it was a better strategy for this training, since Dr. Yasmin is a pediatrician, to be asked to get salary subsidies for these two new positions. So that's where the money goes. Now that says 100,000, but that's because the state gives us 50 and we have to make a match. We have to match their one of the things, and one of the reasons why I continue to apply for this grant, that a lot of these state funds, just because I can explain it, goes to places like Grace Med in Wichita, where you see all the TV community health centers, or basically community health centers, localized. Rural health clinics are also eligible for these funds. I think one of the things that motivates me is that we also have vulnerable populations in our county. We are a federal health professional shortage area for an underserved low-income population, and I think it's important to point that out. Close to 60% of the children in this county, in both of our school districts, qualify for free or reduced price meals. It's around 57, but I'll round it up to 60. And I think that says something about the folks that live here. That's why we do that summer feeding program, and that's part of what I built this grant for. But also, 38% of our patients are basically Medicare patients. And what I notice among our Medicare population that just comes to this hospital, a lot of these elderly people are single and living alone, especially the women. And they're, of course, living out with men. Another demographic that I built into this, in addition to that 38% that are Medicare, is another 15% that are on Medicaid. That's 53% of our patient population is on either Medicare or Medicaid. When you look at the statistics, we also have 7% of our people are self-insured. And that basically probably means that they have no insurance, and they're just the ones who tell us that. So again, that makes 60% of our population has either a government insurance program, Medicare, Medicaid, or no insurance at all. So I think it's important that we apply for these funds because we do serve what they would call a vulnerable population. Our vulnerable population are the frail elderly. Some of the statistics we follow go too far afield, but we have to report the number of individual patients, and I can't quote this, unduplicated patients is what it's called. And then we also track the total number of visits. And the total number of unduplicated patients is basically slowly diminishing. And I think like a lot of other rural counties and communities, what we're seeing is we're seeing those people in the middle. People that are, say, 25 to 45 are basically leaving for greener pastures. So we're left with a lot of young children on one end, but a lot of very ill elderly on the other. Because even though the number of unduplicated patients is falling, our total patient visits continue to go up. And so, and then also those statistics are Medicare and Medicaid. It's just, you know, we're a social service organization, and that's part of what we do. Care for people. So, and the state money is available. All the people in this county have paid taxes. So that's what we try to get some of that. And it's, every year it's going to be higher. Because metropolitan areas, they have a better plan.
Mr. Chairman, I move that the board authorize the board chairman to sign the application for a community-based primary care clinic grant.
Second.
Motion is made and seconded to sign the paper. All in favor, say aye. Aye. Opposed, same sign.
Okay, while we're sort of on that topic, you had talked about the lucrative package that you offered the Chinas. Do you have any details about that?
Sure, but I'd like to discuss that if we could in executive session, since it involves non-elected personnel.
Can we have an executive session?
I'm not allowed to call them. That would be up to a board member to ask for that. I know Mr. Serene's already asked for one, but
Before we go
that would be my preference for life.
Okay.
Before we go to executive sessions, let's talk about the budget.
Okay.
Are we still on new business?
I'm sorry?
Is this still new business?
Yes.
Okay.
Yes, that would be new business.
I was just going to make one comment to get started. Be that how fortunate we are that we live in a county where the taxpayers support this hospital, and we're not like Hillsborough, Horton, or Hilton.
Horton or Oswego.
Oswego.
At this point.
Yeah.
I would second that, Alan. You know, Horton was a city hospital for a number of years. That used to be one of the hospitals I called on when I worked at St. Francis also in Topeka. Hillsborough was also a municipal hospital, or had a hospital city hospital district to fund that, and they were both they and Oswego, I guess. I'm not that familiar with Oswego. Were bought out by a company called HMS, which since morphed into Empower HMS. But the fellow who ran HMS was a fellow by the name of Larry Arthur, who was very famous in healthcare circles in the state of Kansas. But after he sold his business, they really took advantage of some of these small communities.
My other comment on the budget is I see there's some equipment in the lab. I think if you can, maybe we'll have a foundation meeting here in several weeks or so.
Yes.
That would be is that chemistry analyzer.
Yes.
I think that'd be something.
The chemistry analyzer, you know, will be coming up next. I wasn't really prepared to discuss that tonight, but that's on the list. We're going to have to look at a couple of other things. Again, this is a preliminary budget. One of the other things we'll be adding to this, I talked with Erica Kramer today. She's the young lady who runs the radiology department. And we're going to have to acquire some things for our new pediatrician because we don't have really everything that she thinks is necessary. So I've got her working on that list, but that'll be included in the final budget to be presented to you at the March meeting. So Erica and I had that conversation today. I don't know if you want any more information about projections we use.
Any questions on this budget? Wait for the final.
Patience.
Huh?
We just need patience.
Well, we've been doing pretty good census-wise since before Thanksgiving. We of course had a lull right at the holidays, but we always do for Christmas and New Year's. I think what we're blessed with is we have some very good mid-level providers who are not afraid to tackle tough patients and either if need be admit them to our hospital or send them to Salina or Hayes. One of the things that I've noticed in some of our practice patterns, since we're part of the Kansas Clinical Improvement Collaborative, KCIC, and we've got a transportation, proposed provider, emergency transportation provider, we're no longer required to ship our Medicare patients to the closest hospital. They get to choose where they want to go. And we're having a surprising number choose Hayes. And which is, that makes providers happy too, because Hayes is much easier to get patients accepted. So they're just easier to deal with than Salina for the most part.
When you said pediatric equipment, is that under capital budget or is it somewhere else? I didn't see
It's
it.
not in there yet.
Okay,
I
I should add it
I
there.
just
Okay.
spoke with
Okay.
Erica today.
Mm-hmm.
So we will have to add that to that capital budget. But right now, if we were looking at the capital budget, the big things are, and I've still got some grants that I can apply for, but I think a new dishwasher in the kitchen and redoing all of that. That was down again last week for lack of some spare parts. So, but we can go to disposables at that point in time. For that, the laboratory equipment, and then some of this radiology equipment. I just hope to be able to get going on some other grants here before too much longer.
We finished with old business.
I have a new business question I just wanted to ask.
We just-
I wanted you to explain to me, because I don't understand, are our clinic and hospital doctors completely separate from our ER doctors?
Yes and no. Okay?
Okay?
All right. Now, all of our ER providers are mid-level ER providers. Their supervising physician right now is Dr. Dragoni. Okay? So he's their direct supervisor.
Mm-hmm.
We also have a service called Avera eMemergency.
Right, I know Vera.
Okay.
Mm-hmm.
And so, but they consult with our mid-levels in the ER on critical, non-critical, whatever patient the mid-level wants to consult with them on. And so that's why I say yes and no, because they also provide some supervision and guidance to our ER provider. But the thing about that is all of those ER physicians are on our consulting medical staff. It's just that Dr. Bredoni is technically the supervising physician, but since they're on our staff, they can also consult with our midwife.
Okay, I guess what I don't understand is I was talking to some people in Ellsworth, and they were saying that their regular clinic hospital doctors work ER. And to me, that would be really cost efficient because do we have like 50 emergencies? I mean, sometimes isn't it like one or two or none? And then we're paying people to be.
Well, I'm doing this basically from memory. Today is the 26th of February, and to date, I believe we have had approximately 66 ER cases. Our ER has been very busy. Out of those 66 cases, just this month, I think 4 or 5 were admitted to our facility here, and another 4 or 5 were transferred to either Hayes or Salina.
Mm-hmm.
So we've got a very busy ER. The other thing is that prior to my arrival, Dr. Dragoni was taken out of the call rotation, basically because of all the years he was by himself here. And so we set it up so that the ER was covered.
So have we offered that deal to the Chimas?
What deal?
That they don't have to work ER?
Yes. In fact, that was one of their bargaining points. They didn't want to be on call. Nobody wants to be on call anymore.
I know, it just
That's
seems
just
like
the way it is.
a lot of money being paid for ER doctors who do nothing else when it's not like they're handling 40 quick cases a day. You know, maybe 2 or 3 or 4 tops.
Well, I'll have to look, or I know I've got it somewhere, but we do over half or over 1,000 ER cases a year now, and that's in addition to what we're seeing in the clinic and things of that nature. So you won't be able to recruit anybody here if you're going to put them on ER duty.
So no
Nobody-
hospitals do that?
nobody
Is Ellsworth unusual?
I would say yes. But yeah, new young residents that are coming out of family medicine practice, 2 things they don't want is ER or a hospital practice. We can clip off at ER practice, but what keeps us basically financially solvent is our hospital practice. So we have to have physicians that will do a hospital practice, and the Chimas, Mr. Chima, will do a hospital practice.
And clinics. She'll do clinic and he'll do clinic. Okay.
Yeah. But that's just the nature of the beast now, because if you're trained even in Salina, the residents they're training down there do very little hospital work and almost no ER work unless they volunteer to go out and do locums work in a hospital, which some of them do. But there's very little of that anymore. And that started to change about 20 years ago. Their whole thing is having a family life now.
Well, I was just trying to figure out where we could cut money. That
Well,
seems like a huge, huge expense.
Yeah, but they don't want to work as hard as Slumka and what was the other fellows? Yeah, they just none of the ones coming out now want to work like that.
Okay, I just was trying to figure out how that worked.
Is that the end of your new business?
I think so.
Okay, good. Are you ready to move
Yes.
to executive session?
I think I'll try 15 minutes. I hereby move to recess an executive session to discuss potential acquisition of real estate for a new clinic as authorized by Section 75-4319, subsection B, subsection 6 of the Kansas Open Meetings Act for the preliminary discussion, acquisition of real estate, the real property for 15 minutes with Tanya present, and Steve. And we'll reconvene at 15. What's the exact time? I watched my video.
7:20.
7:20.
Okay, a motion to move to executive session has been placed on the board. All in favor, say aye.
Aye.
Opposed, same sign. Motion is carried. We will be in executive session until 20 minutes past the hour.
Another 15
We yada 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 for another 15 minutes. All in favor, say aye. Motion is made and seconded. All in favor, say aye.
Aye.
Opposed, same sign. Motion carried.
To discuss personnel matters of non-elected personnel for 10 minutes with Stephen County present. So reconvening at 4:10.
Motion is made and seconded to go into executive session to discuss personnel matters of non-elected personnel. All in favor, say aye.
Aye.
Opposed, same sign. Motion is carried.
Sorry.
Motion for 10 more additional minutes for executive session for the discussion of personnel. All in favor, say aye.
Aye.
Motion carries.